Okay, I
Now,
will.
yeah,
Shall I
something else
start?
came up.
Shall I start sharing it again?
Yes, sir.
Is it visible?
Yep.
Yeah, that's it.
So then but my screen is frozen, my friends. Ah, doesn't
It's
go
moving,
back.
boss.
Moving?
Yep.
Okay, so let's start from the beginning. Let's rewind and start. So adrenal incidentaloma, I think it's a specialized topic. It needs an algorithm you have to follow to diagnose what the condition is. Whenever you see a mass in the adrenal gland, the first thing you need to decide is whether it's a true adrenal mass or whether it's an adrenal pseudotumor. Now, what do I mean by adrenal pseudotumor? This is how adrenal gland should look like. This is the right adrenal gland, this is the left adrenal gland, pre-contrast, and this is the post-contrast. The easiest way is to see the limbs of the adrenal gland and compare it with the crust of the diaphragm, the crura of the diaphragm. If they are thicker than that, then we say they are hyperplastic. And of course, you look for adenoma if there's an adenoma. Now, these are the things which can come up as an adrenal mass, but they are not. On the left side, a lot of issues which you can get confused with. A gastric diverticulum, an axillary spleen, a splenic lobulation, splenic vessels, splenic aneurysm, artery of the splenic artery aneurysm. So these things you can confuse. Same on the right hand side, not very many, but interposition of colon, small bowel, dilated inferior vena cava, all of these can be confused. So this is the first thing that you have to exclude. Once you've excluded that, then you need to decide whether it's a true adrenal mass. And this is the CT scan of our patient that was just shown, and there is no doubt that this is coming out from the right adrenal gland. It's a nice homogeneous mass. We are told that the density is less than 8. We'll come to what is the importance of density as we go on. The cut that they've taken here, I cannot see the left adrenal gland. So once you decide that it's a true adrenal incidentaloma, adrenal mass, you have to decide whether there are some missed symptoms and signs of adrenal pathology. It happens many a times the patient has got barn door Cushing's or has got symptoms of phaeochromocytoma or has got features of hypoaldosteronism or sex steroids overactivity and they were missed. In which case, it's not an incidentaloma. It's basically a missed diagnosis. So I'm presuming that when we are seeing this CT scan, this has already gone through your mind that you've excluded a pseudotumor, you've excluded the obvious adrenal pathologies, functional tumors, and now you're dealing with a true adrenal incidentaloma. What is an incidentaloma? They are adrenal masses that are greater than 1 centimeter in diameter. Even today, 1 centimeter is the cutoff and appear to be clinically non-functioning, incidentally discovered, like it was discovered in this patient. They are not uncommon. If you take all age groups, the prevalence is probably 1 to 3%. But if you take people above the age of 50 or people above the age of 80, people above the age of 80, as many as 1 in 10 may have an adrenal incidentaloma. That's what it says here, 3% in the middle age and more than 10% in the elderly. So now once you've identified this incidentaloma, as this lady's got rightly confused, what's happening? I came with abdominal pain, which was probably because of inverted commas gas, which settled down, but then you found an adrenal lesion there. So now that you have found it's a true adrenal mass, you need to decide whether it's an adenoma or a non-adenomatous mass. See, adrenal incidentaloma is very much like mathematics. You have to go one step at a time. So whether it's a non-adenomatous mass or whether it's an adenomatous mass. Now, these are the various pathologies which can come up as an adrenal mass incidentally. So it's a huge list. That's what I said, this is something to be dealt by the specialist. Adenoma is the commonest. 80 to 90% are adenomas. The rest, cyst, carcinoma, haematoma, hyperplasia, myelolipoma. Myelolipoma we see quite often. Rarer ones are ganglioneuromas, lymphomas, TB, histoplasma. So if you're dealing with a non-adenomatous adrenal mass, these are obvious on the CT imaging. If it's a myelolipoma or adrenal cyst, uncomplicated, that is where the investigation stops. This lady's mass is not a myelolipoma, is not an adrenal cyst. So we need to move on. If it's an infective adrenal mass, it could be tuberculosis or histoplasmosis. Again, the CT picture is very specific. You should be able to diagnose it. Adrenal lipoma, adrenal lymphoma, ganglioneuroma, hematoma, hemangioma, these are all very rare conditions, but these should be on your mind when you see an adrenal mass. You need to exclude this before you go to the right-hand side, which is adenomatous adrenal incidentaloma. See, 90 to 95% you're dealing with an adrenal adenoma. All this talk that I gave was to deal with the 5% patients when you may get caught. Now, once you have come and decided that this is an adrenal incidentaloma and it is an adenoma, like in Our Lady, then you need to think what kind of adenoma it is. I'm surprised that 5 of you chose phaeochromocytoma. We'll come to it later. Majority of them are non-functioning. About three-fourths are non-functioning. They could be. It varies from series to series. This is a series published about almost 9 years ago now, about 3,000 odd patients. 7% subclinical Cushing's. Aldosteronomas are very rare as incidentalomas. They generally present with hypertension and or hypokalemia. Pheochromocytoma, generally the ballpark figure you should remember is 1 in 20. About 5% of incidentalomas might be pheochromocytomas, and there are radiological hallmarks and hormonal hallmarks which will guide us towards pheochromocytoma. About 4.8 or let's say 5% of them can be adrenocortical carcinoma, and that is something which we have to worry about. So when you see an adrenal mass, it's not a pseudotumor, it's not a non-adenomatous mass, it's a clear-cut adenoma. Then you need to decide whether it's functional or not functional. Functional, you have to exclude hyperaldosteronism, Cushing's, androgen-secreting tumor, pheochromocytoma, and non-functioning, we will come to later as to what we do with non-functioning adrenal incidentalomas. So this is a picture slide. All adrenal adenomatous incidentalomas more than 1 centimeter in size should have only these hormonal workups done. That's why, again, refer to a specialist rather than doing 200 investigations. You just need very focused, specific investigations in adrenal incidentaloma. One is a 1 milligram overnight DEX suppression test. Second is a catecholamine secreting tumor screen. If you have plasma metanephrines, you do plasma-free metanephrines. If you don't have plasma, then you can use 24 hours urine fractionated metanephrines. Only if the patient is hypertensive, like this patient, then you should think about sending plasma aldosterone and plasma renin activity to a PSC-PRA ratio, and we can discuss primary hyperaldosteronism if you have time later on. And all hormonally active tumors have to be removed. So you found a lesion in the adrenal, you decided it's not a pseudotumor, it's an adrenal tumor. Then you decided it's not a non-adenomatous mass, but it is an adrenal adenoma. Now that you've decided it's an adenoma, like this lady, you have to rule out functionality by 1 milligram overnight DEX suppression test, 24 hours. These two have to be done in every patient with incidentaloma, no matter how innocuous it looks to you. You have to exclude subclinical Cushing's and a pheochromocytoma before you can proceed any further while dealing with an incidentaloma. And if they are hormonally active, they need to be removed. So this is what the algorithm now says. Adrenal adenoma, is the adenoma functioning? 1 milligram overnight DEX, plasma-free metanephrines or 24-hour fractionated metanephrines, plasma aldosterone, plasma renin activity only if there's hypertension and or hypokalemia. The sex hormones, DHEAs, testosterone, etc., estrogen, we only send if they're highly suspicious. The suspicion is very high for adrenocortical carcinoma. If it's a functioning adenoma or a malignant mass, I'll come to that later. Laparoscopic adrenalectomy is the most is the treatment of choice. If it's a benign adenoma with subclinical Cushing's, definition is a little bit difficult. I don't want to share that in this audience. We can discuss that later. Then the treatment is individualization. A subclinical Cushing's adenoma does not always have to be removed. You have to see the age, the associated comorbidities, risk for surgery before you go ahead and do operation for an incidentally detected adrenal adenoma, which is subclinical Cushing's. The second thing, so one is functionality, the other is malignancy. Both these investigations run in parallel. Functionality, adenoma has to be removed. Malignant, tumor has to be removed. And how do you decide on malignancy? That's based on the size of the adenoma, density of the lesion on non-contrast, if necessary, delayed contrast washout, as was mentioned in this lady's case, MRI or a FDG PET CT. I'll discuss a little bit with you, but I think this should be left for the specialist. And these are non-functioning adenomas. Additional workup is primarily imaging. And basically, the one imaging that you need is an unenhanced CT scan, the initial imaging procedure of choice. And if your density is less than 10, then you are, as you can see, the specificity is 98%. You're almost sure that this is a benign adrenocortical incidentally detected adenoma. The Hounsfield unit less than 10 signifies it's a lipid-rich adenoma, and adrenocortical carcinomas do not have lipid, so they do not have a baseline CT density of less than 10. Adenomas containing relatively small amounts of lipid, which are called lipid-poor benign adrenocortical adenomas, They are 10 to 40% of them are like that, and there the Hounsfield unit will be more than 10. So there, just by this one criteria, you cannot differentiate between a benign and a malignant adenoma. So if your Hounsfield unit baseline is more than 10, then this delayed contrast washout comes in. This is very, very specific. Again, for not for this audience, probably you need to do the density of the adenoma before giving contrast, immediately within 1 to 2 minutes after giving contrast, and any time between 10 to 15 minutes after giving the contrast. You get the Hounsfield unit value, the CT scan, the computer does it for you, and then you need to calculate the washout. There's an absolute washout, there's a relative washout. 60% is the value which was given for the case, and 60% is what you use for absolute washout. If it's more than 60%, then it is benign. FNAC, do not do, do not do, do not do. That is one take-home point for you. Do not send the patient for FNAC. Let a specialist send for an FNAC. The role for FNAC is very, very limited. If it's an infective lesion, you have to exclude a phaeochromocytoma before. You have to have urine catecholamine values as normal before you put in a needle. It's only in the case of infective masses, TB, histoplasma, or if it's an isolated adrenal metastasis and the diagnosis is going to change management. So is the lesion malignant based on size, based on CT features? Then of course you need to do surgery. Even now they say even less than 6 centimeter adenocortical carcinoma, suspicious carcinomas, you can do laparoscopic adrenalectomy, but open adrenalectomy is preferred in selected cases such as large tumors, large is inverted commas, depends on the surgeon's skill. But of course, if there is local invasion, then 100% it has to be open adrenalectomy. And non-functioning adenomas with indeterminate radiological features. We do not favor adenoma, benign, do not favor adenocortical carcinoma. Size may be big, the imaging, the contrast washout feature may be suggesting benign. In these cases, very difficult, again comes to the specialist. There are three options: wait and watch, do more imaging, or if the patient is suspicious, go ahead and remove it. So approach to adrenal incidentaloma, that was the entire algorithm. I've made it simpler for this audience. That is 1, 2, 3, 4, 5. Is it indeed an adrenal mass? In this case, it is. Is it a functioning adrenal adenoma? We don't know. We haven't done the hormonal workup in this case. Is it a carcinoma? Most likely no. 98% I would say it's no. Size is just cut off 4.1. But if you see the Hounsfield unit pre-contrast scan is less than 10. So it is a lipid-rich adrenal mass, which for all practical purposes is going to be benign. Is it an infective mass? Highly unlikely. Infective mass, the lesion looks, is the typical features of an adrenal tuberculosis or adrenal histoplasmosis. Is it some exotic stuff like hemangioma, myelolipoma, adrenal cyst? Answer is no. So is it adrenal mass? This is how it looks. These are the various things that you have to exclude. Is it a functioning adrenal adenoma? 1 milligram overnight dex test, phaeochromocytoma screen, aldosterone only, patients hypertensive and or hypokalemic, sex steroids only if you're suspecting malignancy. Is it a carcinoma? So carcinoma is basically on size, image phenotype, and interval growth. Three things we endocrinologists see. And this is where this size question comes up again and again and again, whether it's 4 centimeters or whether it's 6 centimeters. So most masses smaller than 4 centimeters are benign, but this is not Bedbakko because 2% of tumors less than 4 centimeters can be malignant. So just size alone does not exclude it. You have to see the various other associated features, including contrast washout. Not every adrenal incidentaloma more than 6 centimeters is cancer. 1 in 4, 25% are cancer, but more than 6%, most people will like to remove it. Is it an infective mass? You need to do an FNAC, like this pictures that you see here. Nice big lesions in the adrenal gland. This was not an incidentaloma. FNAC showed histoplasmosis. So coming back to our patient in the last 30 seconds, size is 4.1 centimeter, just at the cusp, but I would not operate on this. Why? Because it's very well defined, very homogeneous, and it is lipid rich, because if you see the pre-contrast density is 8, and also given if it is less than 8, you don't even need to do a contrast. But if you do a contrast and do a absolute relative washout of more than 60%, then this is a benign incidentaloma. Does she, what this could be? Adrenal incidentaloma. Does she have cancer? In all likelihood, no. But every adrenal incidentaloma needs follow-up for a period of time, which you can decide any time between 1 to 4 years. We can discuss that in question answer time. Is there a risk with a blood pressure because of this tumor? Most probably no, This is highly unlikely to be a phaeochromocytoma because the picture doesn't look like that, but I cannot say it because I don't have post contrast. If it takes up a huge amount of contrast, then I might be suspicious could be a phaeochromocytoma. Those of you who have answered few, you're not wrong, because we need to exclude a phaeochromocytoma in every adrenal incidentaloma. So we should have a 24 hours urine or plasma-free metanephrines if they are normal. Chances that they will be abnormal is 1 in 20, about 4.8 to 5% of the times. Majority of the times they are negative, in which case it will turn out to be a benign adrenal incidentaloma. And this would require, because the size is 4 centimeters, I would probably following this patient up with follow-up CT scans for a duration of anywhere between 2 to 4 years. With that, I will stop. This is the complicated algorithm. So for this audience, I have 3 take-home messages. One is, if you see an adrenal mass, please refer to an endocrinologist, not to a surgeon. Please, 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 because all majority of adrenal masses do not need surgery. Number 2, if you see a mass in the adrenal, the knee-jerk reaction is to do an FNAC. Please don't do an FNAC in adrenal mass. Refer to an endocrinologist. Exclude a phaeochromocytoma. Only then, if you think an FNAC is required, do an FNAC. With that, I will stop. Shomo, back to you. Thank you.